Go.
In your personal opinion, do you think the Affordable Care Act is positive or negative for our nation, and why? What healthcare plan do you think would be the most effective and beneficial for our nation?
Okay. I'm not sure if I think the Affordable Care Act is positive or negative. I think healthcare reform is positive.
Yeah.
So I would agree with that. I don't know if I can really say that this particular Affordable Care Act is the right plan. So I think that's to be determined, and it's probably, sounds like it's happening unless somehow the Supreme Court tells us differently. So what health care plan do you think would be the most effective and beneficial? So if I were looking at reform, when I look at costs, so most reform, there's two parts. One, you need to provide coverage probably to more people, and probably the biggest way you're going to do that is lower costs, hopefully, or make it so people can afford to have coverage. And I still think you need to have some baseline coverage that's either required or provided. Just because there's going to always be people that, I don't care how low cost it is, they can't afford it. They're unemployed, they're the poverty, they're stricken with mental illness, whatever. I mean, they have reasons that they're never going to be able to, frankly, afford it. So you got to provide for those people. And then I would try to look at healthcare. I think I would try to somehow have a body of physicians, not politicians, not healthcare administrators, but physicians in different areas of medicine, at least provide sort of what they think are areas that are things that are positive right now, that we're doing a good job at, and frankly that are fairly cost effective, and things that are frankly we're not doing a good job at and not very cost effective. And I'm sure they've done this to some degree, but orthopedists, which I am, can talk, pretty much know where some of these good things of, we know what we do, and we know where things are sort of loopholes and people get away with things they probably shouldn't be doing, and other things that frankly we do really well at. And I'm sure dermatologists could do the same, and internists and radiologists and all that. So if you had those different specialties or disciplines of medicine, really try to come up with ways that they think that they can improve their care they provide, but also, still keep certain coverage that they're doing a good job at, I would probably look to that. What I see, particularly this is pertinent to orthopedics, is despite technology being good in some ways, it's absolutely driving costs like you can't believe. And I would say most technology in orthopedics that I see is very expensive, it's new, and most of it has not really turned out to make any difference. And some might argue that the results aren't always as good. Now there are exceptions to that, but it drives the cost. And so I think I don't want to take away technology and that innovation that comes from it, but I think that's where in healthcare you need to say, here's the level that we provide coverage for. You need this done, you have a broken bone, you have an arthritic joint or whatever. This is the standard, this is what we can afford to pay. So we have to come up with an affordable amount. Beyond that, if you want something above and beyond, then you need to either pay it yourself, or I guess figure out how somehow someone else is going to pay it for you. But I would say generally it would be you pay it yourself. So right now in orthopedics, there are certain robotic things, customized implants, computer navigated systems. And again, most of it, when they look at these big studies, now that some of this has been out for years, it's like, okay, we can do it. The technology allows us to do it, but the results aren't showing that they're better. And so you can say, oh my God, well, can we afford to be buying $1 million robots and customized implants when what we're doing is providing already a high level of quality. So I think technology needs to be controlled. I think the administrative costs of medicine, and this wouldn't be just for orthopedics, this would be universal, has to be controlled. I mean, we have health systems, insurance, hospital systems that have huge administrative costs. I've been told, I'm going to quote a number, and if you looked at $100 being, $100 being the total healthcare dollars spent. I've been told, or you could just say $1, it wouldn't matter what the amount is. Less than 20% goes to physicians. About 50%, I think, goes to hospitals, the hospital system. I think about 15 or so percent, maybe about 40 to 50% go to hospital. Essentially the same amount that goes to physicians goes to healthcare administrative costs. So that is just and that's not just on the hospital side, it's probably on the insurance, but it's just all these administrative costs just to get your, to approve your, to say that we can approve your insurance or provide that insurance for you so you can pay, or having someone administrate it and overlook it, or run the hospital, or run the insurance plan. To me, that's absurd to think all the physicians providing all the care are the same relative number as the administrative costs, which a lot would say, what do they provide? They do something. But I think Medicare and some of the government-run administrative costs, and they probably play with the numbers a little bit, so I don't know how accurate, but I believe the Kaisers and the government systems probably are running more in the 4 or 5% range, so versus a 15 or 20% that may be in some of the other private sectors. So you have to worry about what that huge number is. The pharmaceutical number, the implant, like artificial joints and things like that number is still a big player, so that healthcare dollar gets eaten up pretty quick. But you have to be able to kind of see where that big picture is and say, hey, these are the areas we need to look at. I mean, if the hospital really is taking 40 to 50%, or the administrative side is taking 15 or 20%, we got to slim that down. I don't know what the right number is, but we got to still come to terms with that. So technology, administrative costs, and then also incentivizing the patient. I think I mentioned that earlier. I think that's huge. So instead of having quality measures that are just based on physicians' performance, which there are ways to measure that by looking at outcomes, readmissions for doctors, results in terms of not just patient satisfaction, but results in terms of the success of maybe a procedure or of a treatment that's administered, in terms of complications or lack thereof, and potentially rewarding those that are doing better. Those things are nice. They're probably difficult to measure. They're probably very expensive to kind of follow. One thing you can do very easily is incentivize the patient. If a patient takes good care of themselves for things that they are actually in control of, diet, smoking, alcohol and drug consumption, wearing seat belts, riding a motorcycle or not, things that we know puts them at risk. And those that are in a lower risk pool, you reward them by lower premiums. And those that are in the higher risk pool, that again are preventable. You're not going to exclude the person that has a genetic, type 1 diabetes that is related to potentially genetics, or cancer, or whatever, certain things that might be more preventable. Now, some stuff, that is related to, they probably have to still look at it closely. I mean, people that smoke a lot get cancer at a higher risk and have higher rates of heart disease, etc. I'm not sure that person should be exempt from the penalties that come with smoking, that kind of thing. If you look at it, if you went over 20 years period of time and you said, look at physicians in terms of their reimbursements for certain things, or their salaries, or their incomes, and then you looked at these 10, 15, 20, 8% increases of healthcare premiums every year, for almost every year for whatever, they're not on the physician side. They're happening on the technology side, they're happening on the hospital side, and then you have to identify loopholes that are areas of abuse. And like 3 areas of abuse that I see, or 2 particularly, pain management has gotten this huge loophole where everyone, they've just pushed pain management. So they've taken these young or middle-aged people that have, quote, pain, and they've made them basically addicts by prescribing medicines. And then the people that provide it, these pain clinics, charge these huge amounts, not just for the pain, but they do tons of procedures with injections and stuff. And it's probably a small part of the pie when you look at the whole picture, but it's just an area of absolute abuse. Most physicians that know anything about it would say, oh my God, it's totally abused, but they do it all the time. Another area is home health services. It's great if someone's an invalid to provide home health care. So someone comes to their house, make sure they're doing some physical therapy or has nursing to help on certain things. That's great. Keep them out of the hospital. But the flip side is everyone says, well, heck, if they provide home health, then anybody that has a knee replacement or any kind of procedure, just let's have the home health go in there. It's extremely expensive to have someone driving around looking for your house and spending not only the money to do it, but also that particular provider, whether it's a nurse, a therapist, a whoever, is probably only seeing half, if that, of the people they normally would, because they're spending the time driving to the patient. I got to tell you, most of the time the patient has more time to be getting to the physician or the service that's provided than vice versa. So you have to rearrange that. Now that doesn't mean we shouldn't try to keep people out of hospitals. And I really think long-term, probably the biggest area of medicine is preventative care. I mean, really getting people to take care of themselves. And that's where I would put the emphasis, and not have, the government, necessarily demanding it. You incentivize them, and I hate to say it, the cost is an incentive for people.